Today I'm going to talk about macular edema and OCT. These are my financial disclosures. Macular edema means increased thickness of the retina. This increased thickness of the retina can either be central or paracentral. So what is the definition of thickness and how do we grade thickness? Thickness will be different in the stratus versus the serous OCT. In the stratus OCT, the measurement is there from the internal limiting membrane to the ISOS junction, while in the serous, the measurement is taken till the outer footplate of the ISOS junction, which shows that in a patient, if you do the same patient with a stratus versus a serous, in the serous OCT, the normal would be around 50 microns thicker than the stratus. The origin of this thickening can be various. It can be pre-retinal, intraretinal or subretinal with leakage, or there may be just spillover edema, as we shall see in the next slide. Whenever we talk about macular edema, one can have certain lesions in the retina. These lesions can be exudate, blood or a scar. If you see over here, as Dr. Dubey showed, this patient has lipid exudates, which can be seen as focal areas of hyperreflectivity. Sometimes these focal areas of hyperreflectivity can coalesce together. So whenever you see a lesion over here which is hyperreflective, it does not mean it is lipid. It can mean any of the three things: lipid, blood or scar. And one has to look at the clinical picture to complete the diagnosis. Here is another patient with pigmentation in a patient with parafoveal telangiectasia, which is a hyperreflective lesion over here, and this hyperreflective lesion shadows the lesion which is behind it, and hence you cannot see the lesion behind it. A hyporeflective lesion can be in the form of serous fluid, and this serous fluid can accumulate and give rise to the formation of cysts. If you see over here, there is diabetic macular edema with cyst formation. What about prognosis in patients with macular edema? As Lalit has showed, that if there is a disrupted ISOS junction or a disrupted external limiting membrane, it may mean that even after the normal anatomy is restored, the patient's vision may not improve. However, if you see over here, what happens is that because of the cystic changes, one cannot image the next layer very well, and hence the ISOS junction layer is not imaged. We shall see this example in the next few slides. Now, when we do a patient of diabetic retinopathy, we subject the patient to OCT. What are the patterns which are seen? One can see a spongy pattern, cystic pattern, a serous detachment, a foveal traction, or the taut posterior hyaloid face. This is a patient who has a spongy pattern, and this spongy pattern is extending throughout the macula. While in this patient, again you have a spongy pattern which is localized to the superiotemporal quadrant, which shows that the thickening is localized and limited only to this area. Patients who have a cystic edema can have either only a cystic edema, or in this patient has a cystic edema along with a diffuse spongy pattern, along with a little subserous exudation also over here. So all these patterns can coexist together and they are not seen in isolation. This is again another patient with cystic pattern, and if you see the correlation on the FFA, there is a lot of leakage over here, and similarly this is shown as a spongy pattern over here and a cystic edema in the center. One can have patients who have vitreomacular traction. Like this is a patient who I have myself been following up for the past 5 years and have never advised her surgery. And this time when she came, she developed a little bleed, and I said, let me do a OCT and see. And the OCT showed that the patient had a vitreomacular traction. Patient's vision was stable for the past 4 to 5 years at 636. I said to the patient, well, let's go in and try and do a surgery and see if you improve. And we did a surgery. The patient's edema was relieved, and the patient's vision improved from 636 to 6/18 in this patient. One can also have a vitreomacular traction which is not vertical but which is taut and horizontal, as Lalit has described. And here you can see a thin epiretinal membrane with a taut PHF, which we do a surgery for, and the macular edema reduces and the patient's vision has improved again significantly. What about branch and central retinal vein occlusion? In these patients, the OCT helps us to show retinal edema, the retinal ischemia, and a response to treatment. Let's see this example. This is a patient with a central retinal vein occlusion, who has a lot of areas of peripheral ischemia also. And if you see the OCT, it shows severe macular edema with cystic changes. Now, because of this, you cannot image the ISOS junction or the external limiting membrane. We gave this patient anti-VEGF injections, and over the period of the next 4 months, you can see that this patient's vision steadily kept on improving. I also had a surprise. The patient's vision improved from 3/60 over here to 6/9 over here in the next 3 to 4 months. Then, on the 5th month, the patient had again a recurrence and the patient's vision dropped to 6/18. We gave one more anti-VEGF, and again the patient's contour was restored with a restoration of the vision. So OCT in these vein occlusion patients also helps us to determine the prognosis of treatment, and also helps us to detect recurrent macular edema at a very early stage. What about cystoid macular edema? This is divided into 3 categories. One can have Irving gas syndrome, uveitis or pastinitis or leakage, and cystoid edema secondary to other vasculitis like Eales disease. This is a patient again who had been operated for cataract. Also, this was a patient with pastinitis with CME, and here is the response to posterior subtenon triamcinolone. You can see that this edema which was there has now gone off with restoration of the patient's vision. This is another patient with leakage, with disc edema and diffuse serous PEDs everywhere, who had a small serous PED over here and was treated with intravenous steroids to give rise to a good vision result. The most important thing in patients with edema is the hidden membrane. Very often one finds that there is a thin, subtle ILM or posterior hyaloid or thin epiretinal membrane which is not seen clinically and sometimes not seen on the first examination of OCT also, and subsequently shown up in serial examinations, and one needs to tackle this membrane surgically in order to reduce the macular edema. So sometimes you have patients who have a so-called leakage on the FFA but no fluid. These patients are patients with parafoveal telangiectasia with membranes, heredomacular degeneration, retinal ischemia, hypertensive retinopathy, or patients with mutes. Here you see a patient with heredomacular degeneration which is showing Stargardt disease with staining over here, and you can see that the retina is very thin and atrophic. This is another patient with a parafoveal telangiectasia with a secondary colloidal neovascular membrane which is showing the membrane over here and a response to treatment. Now this same patient had parafoveal telangiectasia in the other eye also, which showed a diffuse staining over here. Mind you, this is staining on the FFA and not leakage. The way to identify this is do a OCT, and the OCT will not show you any thickening. However, what happened over a period of time that we followed this patient up was that this patient over the next 6 months developed a small colloidal neovascular membrane over here which was detected immediately on the OCT, given anti-VEGF treatment, and resolved completely over here. This was a patient who was scheduled again for fundus fluorescent angiography. We saw the patient on the clinical examination, and I thought the patient had a high blood pressure. Asked the anesthetist to take the blood pressure, and the blood pressure was 220/160. And you can see that there is a diffuse subretinal fluid over here, which is very characteristic of severe malignant hypertension and hypertensive retinopathy. What about ischemic retina? In patients who have ischemic retina, the entire retina is thin and compacted and very hyperreflective. So in patients with central retinal artery occlusion, if you do a OCT later on, you don't see macular edema, though sometimes you may see a little staining on the fundus fluorescent angiography, but this retina is very thinned out and hyperreflective. There's another condition where you get a thick retina, and that is myopic retinoschisis. I purposely included this over here because this retina looks like having a macular edema if you see this picture. These patients have a reduced vision. When you observe the OCT very closely, you have this thin membrane over here which is giving rise to traction and giving rise to increase in the thickness of this retina. We do a surgery and remove this membrane, and this is the color pictures which don't show any difference. But if you see this OCT, this in the period of 1 month has reduced. The patient went to his village and came back to us 6 months later. And 6 months later, you can see that this retina had almost completely flattened out with the patient's vision improving. Sometimes we have no leakage on FFA, but yet the OCT when we do shows macular edema. These are patients with optic neuritis, optic disc pit, or long-standing CSR. This is a patient again with optic neuritis. You can see that the primary leakage is at the level of the optic nerve. However, when one passes the vector through the macula, one gets spillover edema over here, and this also contributes to reduction of the patient's vision. And this patient requires IV methylprednisolone. Now this is another take-home message which I would like to give, and that is, when you see this patient, very often as retinal surgeons, we get OCT thrust into our hands by a patient's relative. That doctor, my patient has undergone a OCT at XYZ place and patient can't come to us. You can look at this patient. If you see this patient, it shows that there is spongy edema over here, but there is also maybe a thin membrane. This picture doesn't show you much. But when you ask for the clinical examination, do a FFA, this is what the picture shows you. It shows you that the patient has had a diabetic retinopathy with proliferative diabetic retinopathy over here. There is NVEX peripherally, and there is a macular edema over here with a thin membrane. So the prognosis of this patient, the treatment of this patient completely differs. So it's very important not just to see the OCT, but to see the patient as a whole. Again, this is another patient with macular edema, with different pictures taken at the same time at different levels. If you see, this shows subretinal fluid, this shows cystoid macular edema, this shows cystoid macular edema with a subretinal fluid, this shows only subretinal fluid. What did the patient have? An inferior temporal retinal detachment with cystoid macular edema. So what does OCT show as far as macular edema is concerned? It shows us that the structural changes and the traction can be identified. However, it shows that vascular changes cannot be identified. It's non-specific for the exact size of leakage, but it is excellent for assessing the response